So today's class is on obstructive airway diseases. We have already seen a short introduction on obstructive and restrictive airway diseases in the last class. So which are those obstructive airway diseases? It includes four diseases basically. They are emphysema, chronic bronchitis, asthma and bronchiectasis. Okay, so we'll see two of them in today's class. So, what is emphysema? Emphysema is defined as the definition is very important. It is a abnormal permanent dilatation. Okay, abnormal permanent dilatation of air spaces distal to the terminal bronchioles. Okay, which is distal to the terminal bronchioles, and that is also accompanied by a destruction of the alveolar septa. Okay, destruction of the alveolar septa, and there is dilatation of the that's air spaces distal to the terminal bronchiole. And emphysema are classified into different types based on the location of this dilated air spaces. So that includes centri acina, pan acina, paraseptal and irregular. Okay, so this is a pictorial representation of how the emphysema looks like. You can see the distal air sacs are dilated permanently. Okay, so this is how it looks like. So the alveolar sacs will be the distal most part of the respiratory system. So of these, few of them are dilated. So always this emphysema here, the alveolar sacs which are dilated will be distal to the terminal bronchiole. You can see the relation between the bronchiole, terminal bronchiole, etc. Okay, so again the same thing. Now first we speak about central SNR emphysema. So here which part is affected is the central or proximal part of the SNI. That is the respiratory bronchioles which are involved. Okay, and that is more commonly seen in certain parts and certain individuals. It is seen in central, upper lobe of the lung, upper lobe and also the apical segment. And the central SNR is more commonly seen in heavy smokers. So that is a peculiar association. So heavy smokers, upper lobe, apical segment is the most common location of central SNR, is the most of features which are associated with central SNR. So see here, this is a normal SNI with respiratory bronchiole and alveoli. So in central SNR, you have the respiratory bronchiole part which is affected. That is the central portion. Whereas you see pan SNR here, that is a distal, the whole alveoli, the whole distal SNI is involved. That is a pan SNR. So this is the gross picture of lung. You know the lung, normally it is very spongy, but here you can see multiple dilated cystic spaces. Why the cystic spaces are seen? Because they are all dilated alveolar sacs. Okay, so it is seen as cystic spaces in the lung. This is a microscopic picture. You can see it's actually a cross section of the alveoli. You can see multiple normal alveoli over the periphery, but in the center, what are you seeing is a big dilated alveolar sac, and also some septal fibrosis, minimal septal fibrosis, and septal destruction of the alveolar septa is also seen. Now pan-SNR emphysema is the second type, which is we have already seen the diagram. It is seen as dilated alveolar sacs towards the lower zones and also the anterior margins at the attachment of the pleura. And this another entity which is associated with this pan-SNR is alpha-1 antitrypsin deficiency. So what is the association? We'll see in detail about when we see the pathogenesis. Okay, so here you can see the distal part of the alveoli is enlarged. Okay, so this is distal. Okay, same thing in the microscopy also there will be septal degeneration, septal destruction. Now paraseptal emphysema is another type of emphysema where you get the distal part of the SNI which is involved, the most distal part, and the margins of the lobes adjacent to the fibrosis, atelectasis, scarring, etc. is involved. Okay, so that is known as paraseptal, the septa which is adjacent to the fibrotic area, the atelectasis, the scarred area, etc. are involved. and the enlarged air spaces may come around 0.5 to 2 centimeters in diameter, and that is also another common cause of a spontaneous pneumothorax. Why? Because this emphysematous air spaces are situated very close to the pleura. So what happens when this air spaces rupture in any manner, that will cause air in the pleural cavity or in the thoracic cavity. So that results in a spontaneous pneumothorax. So that is a paraseptal, it is near the septum or the fibrotic or atelectatic area which is close to the pleura. Now we'll see few words about the pathogenesis. How is this emphysema happening? This is also very important. Basically there is inflammation which is in the background of emphysema, but that is mild chronic inflammation, and also there is a role for macrophages, neutrophils, and also CD8 plus T lymphocytes, and they release lot of mediators like leukotrienes, interleukin 8, etc. Now what happens when there is more exposure to smoking? Basically all the COPD, these things are seen in smokers, especially emphysema, chronic bronchitis. They are seen in chronic smokers. So there will be a history of smoking. And what happens when there is smoking? There will be oxidative stress to the patient with increased apoptosis and senescence of cells. And also there will be release of inflammatory mediators from the inflammatory cells. Also there is another thing which is important in emphysema, that is protease antiprotease imbalance. What is this thing? You know that normally there will be lot of proteases in our body. Normally you have lot of enzymes which destroy the proteins, like elastic proteins of the alveolar wall. There will be elastic proteins in the alveolar wall which helps in stretching of the alveoli due to when it fills during respiration. So what happens if there is increased protease? It will undergo destruction. But normally there is another mechanism that is known as antiprotease, which will inhibit this protease action, and that is this balance, that is a protease antiprotease balance, which prevents the development of emphysema. But what happens when this patient or people are exposed to smoking, air pollution, etc.? This protease antiprotease balance is lost. Okay. Also another common condition, another rare condition actually, which cause this antiprotease-protease imbalance, is known as congenital alpha-1 antitrypsin deficiency. So antitrypsin is actually an antiprotease. Okay, so what happens if the antiprotease or the antitrypsin is deficient? That will result in increased protease activity. So protease activity means there will be increased destruction of the proteins, that is the elastic fibers of the alveoli. So that results in alveolar wall destruction. So that I told you, this is the thing. And homozygous patients with alpha-1 antitrypsin deficiency have increased tendency for emphysema. Again, role of smoking. Smoking induces an inflammatory background that induces inflammatory cells to proliferate and also to release mediators, also in increasing free radicals. Okay. Now grossly, I told you, mostly the lungs will be enlarged. Why? Because the air spaces are dilated. So the size of the lung will be very high. Okay, so it will be voluminous lung, and 1/3 of the lung parenchyma should be damaged for clinical manifestations to occur. So patient presents with progressive dyspnea, cough, wheezing, weight loss, and the typical chest appearance is known as a barrel-shaped chest. So barrel-shaped chest is, you might have learned in your medicine classes, you have barrel-shaped chest. So this is a barrel-shaped chest because of that voluminous lung. And in severe emphysema, there will be severe overdistension with a very less diffusion capacity. What is happening here actually? The basic mechanism is air is getting inside the dilated air spaces, and it is getting trapped there. So that's why this lung volume is increased. So the expiration will be less. There will not be any inspiratory problem, but there will be expiratory problem. So there's air trapping inside the lung. Okay, so that means the patient will get over ventilated, and so he is actually well oxygenated, because oxygenation is happening because he is over ventilated. But so those patients will be pink, or he is well oxygenated. There is no issue of deoxygenation, so he will be pink. So that is well oxygenated and hyperventilated. So they are known as pink puffers. Pink puffers. Okay. So we'll move on to the next COPD, that is chronic bronchitis. What is the definition of a chronic bronchitis? That is a persistent cough for at least 3 months in 2 consecutive years. So that is known as chronic bronchitis. Okay, different clinical terminologies are there, but just remember that there should be persistent cough for at least 3 months in 2 consecutive years. What is the pathogenesis? Again, the pathogenesis is due to irritation caused by tobacco smoke and also environmental and occupational hazards. And there can be acute exacerbations. That is another important thing you should understand, that both this emphysema, chronic bronchitis, as well as asthma, bronchiectasis, etc., will have acute exacerbations. What do you mean by exacerbations? These patients will develop infections or super added infections over this lung pathology. So these patients are more prone for developing secondary infections. So that is known as acute exacerbations. So that is caused by bacterial and viral agents. And what are the features of chronic bronchitis? There will be hypersecretion of mucus with hypertrophy of the submucosal glands. Okay, and also there will be increase in the goblet cells. So these are the 3 important features. There will be increased secretion of the mucus, there will be increased glands, there will be increased goblet cells. So these 3 features you should keep it in your mind. Now, what is the morphology of chronic bronchitis? The patient will have his hyperemic mucous membranes swollen, which is edematous mucosa, the bronchial mucosa. Okay, there will be excessive mucinous and mucopurulent secretions. He will have cough, severe cough with expectoration. And another term we have to remember is that is known as Reed index. What do you mean by this Reed index? Reed index is nothing but which measures the thickness of the mucous gland layer to the thickness between the epithelium and the cartilage. You will see when you see this picture. So here this is a normal bronchial epithelium with the pseudostratified ciliated columnar epithelium, and underlying that you can see the normal bronchial mucus glands. So what happens in and also there's a cartilage layer beneath that. Okay, so that A marked one is epithelium. So what happens in this is a normal thing. Normally, what is the ratio? That is 0.4. That is the ratio of the thickness of the mucus glands to that of the total epithelial thickness. That is 0.4. Okay, that will be 0.4 because the glandular part is very less. Okay, so what happens? This is a normal thing. Okay, so what happens when there is a bronchial hypersecretion? The mucosal glands will be increased. So what happens? That ratio, the glandular part, that arrow mark, that area will be increased, or the thickness of that mucus gland will be more. So that's why the patient is having more mucosecretions. He has expectoration, cough with expectoration, increased sputum production. So all these are due to this increased hypertrophy of the mucus glands. Now what are the clinical features? The patients will have persistent cough with productive sputum. Again, patients will have dyspnea on exertion, hypercapnia. Here the thing is reversed. When compared to emphysema, patients with chronic bronchitis will have hypercapnia. That means patient will be having hypoxia. The carbon dioxide will be retained. Okay, the retention of carbon dioxide will be there, and also because of this deoxygenated blood, the oxygen saturation will be very less, so the patient will have cyanosis. Okay, so cyanosis will be there, hypercapnia and hypoxia. So that's why the patients with the chronic bronchitis are often known as blue blotters, because they will be blue or cyanosed because of the less oxygen and more carbon dioxide content. Okay, so and also long standing cases of both this COPDs, they can lead to heart failure. Okay, that is right heart failure, that is cor pulmonale. It's known as cor pulmonale. So these are the blue blotters. Okay, they will be cyanosed because of hypoxia, because of reduced oxygen content in the blood. So that is the last slide. You can see the differences between chronic bronchitis predominant COPD and chronic emphysema predominant COPD. So basically both looks like the same. The patient's presentation will be the same, like cough will be there, dyspnea will be there, but we can get supraellar infections also. But we have the elastic recoil, which is low in emphysema because of the destruction of the alveolar walls, whereas it is normal in chronic bronchitis. And also in chest radiograph, you have hyperinflation. You have more very big, very elongated sort of lung shadow in emphysema because it is hyperinflated, whereas you have almost normal size lung in a chronic bronchitis. And also appearance wise, so this is a blue blotter in bronchitis and pink puffer in case of emphysema. Okay, so this with this we are stopping this class. Next class you will learn about bronchiectasis and asthma. Okay, thank you.